The following podcast is part of a certified educational activity titled Fast Track to Relief, Accelerating Treatment Initiation and Supporting Patient Follow-up in Pediatric Eosinophilic Esophagitis. Access the entire activity and complete the post-test at peerview.com/BHC860. Downloadable slides and practice aids are also available.
Hello, and welcome to this educational activity on accelerating treatment initiation and supporting follow-up in pediatric EoE. I'm Jennifer Lightdale from Boston Children's Hospital, and joining me today are my colleague, Sandeep Gupta from the University of Alabama at Birmingham, and Samantha Foster, a parent whose son was diagnosed with EoE about 2 years ago.
Thank you, Dr. Lightdale. We are glad to be here today.
Thank you for having me.
Great. Our goals for today are to improve your ability as clinicians to identify common barriers that contribute to delayed diagnosis and treatment initiation in pediatric EoE, to equip you with strategies to reduce time from diagnosis to treatment initiation, to provide guidance on conducting comprehensive discussions with patients and families when conveying an initial diagnosis of EoE. And we essentially have 3 sections, so this is the way the talk will be organized. In terms of the first section, which is reducing diagnostic delays and expediting early intervention in pediatric EoE, I want to start by saying that diagnostic delay in EoE is unfortunately common. We do know that the time between symptom onset of EoE and diagnosis has ranged in various studies. And in one, we saw it between 1 and almost 4 years in children and up to 8 years in adults from when you first have symptoms to when the diagnosis is made. And this was really from a study done by Nick Shaheen of 705 patients with EoE that ranged from 6 months to 65 years. And what was really interesting is that the median time from symptom onset to diagnosis was about 1 year in children who were less than 11 years of age, 2 years in children who were middle school to high school, and then 4 years in adults. So how do you recognize the condition? The answer is to think about it, and also to think about family history and food allergy and atopic dermatitis. And indeed, that study found that if there was food allergy and atopic dermatitis, you were able to pick up on the diagnosis sooner. So when you're hearing about allergy, you're thinking about EoE. And early diagnosis is important. And Sam is going to talk to us more about this. But if you don't control EoE, over time, you're having worse symptoms. And the worst symptom of all is esophageal stricture. And we do know of patients with severe diagnostic delay, those who waited years, over 50% had food impactions and a stricture. In terms of what's really relevant for children, you see a lot of feeding dysfunction. So up to 60% of patients with EoE will have feeding dysfunction. If you're not picking up on it, they are not eating well and nobody understands why. And also can be losing weight or not thriving. So about a fifth of the kids with EoE and feeding disorders were classified as failure to thrive. And all of this has a terrible negative impact on quality of life where people are feeling badly, like they can't understand why their child can't eat. We do know that EoE signs and symptoms really vary among children and adults, and we see differences in symptom presentation. So in infants and children, you can have reflux-like symptoms, vomiting and nausea, abdominal pain. But again, that food refusal and failure to thrive are big tip-offs. And then later in life, in adolescents and adults, they're more classically having difficulty swallowing, can articulate that they have difficulty swallowing. So dysphagia, can feel food get stuck, can have substernal chest pain even, or reflux-like symptoms. And all of that certainly will get your attention. And this has been known for many years. So really early studies of EoE showed that in very young children, it's all about feeding disorders. And then as you get older, it's about food impaction. And all of that is because of delay or not picking up on the diagnosis, or the person themselves not understanding what's going on, that allows fibrostenosis to happen in the wall of the esophagus, and you start to get scarring of the esophagus. how can people go that long without a diagnosis? So it turns out people really develop adaptive behaviors. They just do these sort of almost unconsciously, but that can mask symptoms. And actually a very nice way of remembering what to ask for was put together by Dr. Hirano and Dr. Furuta, who are two big gurus of the field, who came up with what they call the impact score, where you want to ask if someone is imbibing fluids, if they're drinking a lot of fluids, if they take water after every time they take a bite of food, that should get your attention. If they're cutting their food into very small pieces, or with a child, if the parent feels like they have to cut the food, modify the food by cutting it. If the meal times take a really long time, so someone's the last at the table always, if they're avoiding harder texture foods, they're chewing excessively, almost afraid to swallow. And then in older people, if you're turning away pills and tablets because you just can't swallow them, or you feel that they get stuck, all of that are adaptive behaviors that people who don't understand why they have difficulty swallowing are starting to show. And you can ask about that in the office and pick up the diagnosis. So the updated EoE diagnostic algorithm really says if you're thinking about EoE and they're having symptoms and you're asking about these maybe adaptive behaviors, or there's feeding dysfunction, and then if the patient themselves has atopic conditions, or there's family history of atopy, certainly family history of EoE, EGID, all of that should say, yeah, I think I need to think about EoE. And then the first thing you really are doing when you've decided you're thinking about EoE is an endoscopy. And that's because to make the diagnosis, you do need to get biopsies. With biopsies, we're looking for eosinophils in the wall of the esophagus, so what we call esophageal eosinophilia, at least 15 eosinophils per high-powered field. You should have 0 eosinophils in your esophagus when you're normal. When you get to more than 15, you're starting to think very much about EoE. And you're also considering other things that could do this. So there is a differential diagnosis, but ultimately that's really how you're going to get to the diagnosis of EoE. So these are things you can see when you do endoscopy. You can see rings, you can see furrows, which look like the little ski tracks. You can see exudates, like those little white dots, which look a lot like yeast, but they're not. There are tons of eosinophils in those. And all of that can, as I said, lead to scarring of the esophagus or swelling of it. And you can certainly get food get stuck. And that's a picture of food stuck. And we do score every endoscopy now with what they call the EoE endoscopic reference score. And that's because there is some gradation to this. As it gets more severe, you may see more of all of these different findings. So we score all of them. But again, it's really all about recognizing those symptoms, identifying the patient, and then getting the patient to the endoscopist or gastroenterologist who can make sure that an endoscopy gets done. So there, I think it's important that families understand you're thinking about EoE, and that is an endoscopic diagnosis. And it is important, I think, that the first providers say, I'm wondering if you could have a condition I've been learning about called EoE. That requires a gastroenterologist who needs to do an endoscopy. And I think for a family to hear that from the very first provider that they see will help them understand that that's the way we make the diagnosis. And of course, ensure that they are supported through any logistical or financial challenges. So, for me, this can be a barrier. So if the family doesn't understand that I need to do endoscopy, they can balk. They can say, wait, I didn't know that I was going to need a procedure for this. So for me, is helpful if a pediatrician or nurse practitioner, or certainly the first clinician who's thinking about EoE says, okay, this is an endoscopic diagnosis. It's then on us in pediatric GI to make sure we're guiding our families in simple terms about what to expect before, during, and after a procedure. And procedures are in my world, and I'm sure in Sandeep's world, they are fairly straightforward. It's honestly less than a 10-minute procedure, but we always want the child very comfortable. So most of us work with anesthesiologists, and the child will be monitored by the anesthesiologist as they're sedated for the procedure. But again, a lot of this is about getting the family to understand that that's the test you want to do. And we want to be providing reassurance to help reduce anxiety and build trust. and make sure the family feels like they're in control of the care. So doing that all together is what it's about. Um, I am interested in what Sam thinks would be useful words. I will tell you that we try to use simple language. You want to present the diagnosis in plain language, talk about EoE as a condition where the esophagus is irritated and inflamed due to allergy. To the child, you want to make sure they're comfortable with what's going on. So, at the right ages, talking about the esophagus like a water pipe that's getting blocked by food because the body's having an allergy. A lot of children understand allergies these days. And then you do want to make sure the family understands that you're thinking ahead. It's not just what's going on at that moment, but understanding that if untreated, the EoE can cause scarring and narrowing of the esophagus, which makes it hard for the child to swallow food over time. And certainly you need to address family concerns and assure them that once you know you're dealing with EoE, now you can start figuring out how to treat it. And Sam, I don't know if you have magic words but I think it would be great to hear a little bit about your story, your son's story, how this diagnosis came to be in your life, and maybe tell us a little bit about that, if that's okay.
Yes, of course. So our son Cam was exhibiting just some abnormal symptoms around the age of 10, and it took about 16 months or so to receive a diagnosis. We went to our pediatrician multiple times with a lot of the symptoms that you had charted earlier, and it was just something our pediatrician didn't understand. They actually encouraged us to get him some mental health therapies because they didn't understand why he would have these symptoms for such a long period of time. And it keeps exhibiting itself like a strep throat and vomiting and lots of reflux. And they just didn't think that it was something that could maintain that length of time without being eradicated with the medications. And so we advocated for Cam and ended up at our local children's after we received a referral. And we had never heard the term EoE. I didn't know what it was. Neither did Cam. We didn't know anybody that was experiencing anything like this. But 16 months into it, and a lot of different medications and doubt and just uncertainty, when the doctors were able to tell us, we think it's one of these two conditions, the only way that we can be sure and we can find treatment to help Cam get back to his quality of life and what he knew prior to this. The only way to do that was with having this procedure done. As scary as the procedure was, we we trusted what the doctors were telling us. They laid it out in very simple terms, so we could understand that it was going to be very quick. They answered all of our questions. Most importantly, they helped Cam to feel comfortable because at this point he was 11. And so they explained it to him in a way that he could understand, a way that made him feel comfortable. And truly, they just helped us see that if we wanted to find what was at the root of everything, this was the only way to achieve that. And if we could go ahead and get treatment started, it would help it would help make it to where he didn't have further damage later on in life and have these impactions and all of these other complications that you can see later on if it goes undiagnosed.
No, it's quite a story, and it does sound like it maps to what I was talking about in terms of and again, once you're thinking about it, I think it is possible for everyone to think about EoE. It's just a little hidden because it's in this esophagus. You use the word damage. Does that word work for you? Does talk about damage to the esophagus?
It did. As a parent, you hear the word damage and you want to, something's wrong. You know that something needs to be fixed. And that word really, it resonated with me. It helped me understand the importance that if we don't do something, we can have further damage and what that might look like for his quality of life. Maybe not necessarily now, but later on. And so the importance of getting in front of that as fast as we could, that really resonated with us and made us push to go ahead and had the upper endoscopy done, and ultimately led to his diagnosis of EoE.
Wonderful. And thank you for sharing that. I am going to turn this over to Dr. Gupta for the second section.
Great. Thank you. Thanks, Dr. Lydell. That was a fantastic introduction to getting to the diagnosis and what many people go through. And Sam, thanks a lot for sharing your journey so far. Definitely sounds like you were kept engaged by your care team once you got to where you needed to be. And now we'll talk about what to do when a diagnosis is made. It can be quite overwhelming, and not only that you have a new diagnosis, but you have a diagnosis that can be a long-term diagnosis. It's not like an ear infection or a sore throat that you give a one-time treatment for 10 days and you're done. And then a term that is so difficult to sometimes even articulate, eosinophilic esophagitis or EoE. And sometimes it's good to break it down into pieces for the families. And something I do is I say eosinophils are the type of cells that are inflaming or damaging the food pipe. So that's where the word eosinophil, and esophagitis is that's the other name for the food pipe, and that is irritated. And so kind of just for them to understand and to come to the lingo that we normally comes to us on a daily basis. But our family is the first time they're hearing something along those lines. And I think going to the next step after making a diagnosis is what do you do for it? And that's what everybody's mind is, including when we are as patients, we want to know, okay, you made a diagnosis, doc, where do I go from here and get my life back to some degree? This is a very nice flow diagram of the options for EoE or eosinophilic esophagitis. I'll go through that. It'll take a little bit, but most of the treatment centers around this flow diagram. So once a diagnosis is made, we go to one of the two top blue squares, the dark blue, which is pharmacological therapy, or the light blue, which is dietary modifications. Let's do the diet part first. Dietary modifications could be an elemental diet where most of the things are removed from the diet. And that's not done very often nowadays, but that's how the initial studies in the 90s came by, using a formula and a couple of foods in the child's diet. Or what we now call empiric diets, where we take out foods that we presume are more likely to be offending agents in a child with EoE. And those are in sequence are milk, which is the most common, followed by wheat, egg, soy, then fish and nuts. So if you take out all six, it's called a 6-food elimination diet. If you take out the top four, which is milk, wheat, egg, and soy, is called the 4-food elimination diet. If you take out milk and wheat, it's called the 2-food elimination diet. You get the gist. So most often milk is, and when you do take these out, you go in the reverse order of putting them back in, and milk comes the last thing that is put back in the diet. Or you can do the pharmacological therapy, where there are three main types: is the PPI, proton pump inhibitors, acid blockers, or topical steroids, or dupilumab. Dupilumab is a biologic agent, and we are very familiar with PPIs. And then the topical corticosteroids are drugs that are used in the nebulizer machine. That's how they started. One initially was Flovent inhaler, then budesonide also is that respule that goes in a nebulizer. And more recently, there is a budesonide formulation that is FDA approved. Instead of mixing the budesonide in a carrier, it's already mixed in. What I tell families is these are my 4 options. These are our 4 options. We have to decide what to do. But to help them make a decision, I also tell them upfront that endoscopies are going to be needed to assess for the diet, what the therapy is doing. And I give the example of a chronic condition like diabetes or hypertension, where you just don't take your medicines and nothing else is done. If you have diabetes, you get blood checks every now and then. If you have hypertension, you get a blood pressure done. Same with EoE, we have to assess what the treatment is doing, how the disease is staying under control. And for that, at present, all we have is endoscopy with biopsies. So that really helps me when Dr. Lytle mentioned about building upon the endoscopy framework initially. That, and if they have had a good experience, or at least not a negative experience, that really builds into the follow-up part. And it's really important to be upfront with the families and saying endoscopy is going to be needed to assess how my treatment is working. And so at this point, I also share with them my personal experience on response rates. So because everybody wants to know what's best or which one do I do, in my experience, PPIs are generally about 30 to 40% response rate. For the other three, topical corticosteroids or empiric diet, not elemental diet where you take most things out, but empiric diet or the 4 or the 6-foot elimination diet, or dupilumab, in my experience, is usually 60 to 70% response rate. Some little bit more, some a little bit less, but kind of in that general ballpark figure. So that's how I lay the land for the families. I share all the 4 options with them. And in my mind, though, I'm thinking, okay, what do I need to do if the family chooses an option that may not be the best for the child? But I give them a chance to first select. And in that, I'm thinking if they're super narrowed, if they're fibrostenotic, I may want to go get more aggressive up front rather than go stepwise. But this is what I normally tell the families up front. These are my 4 options. No matter what we do, we'll probably have to do an endoscopy, generally 2 to 3 months after most of them, except dupilumab, which is 4 to 6 months based on the studies that were published. So we move from there. I outline those things, and then we go to shared decision making, where the caregiver, the patient, and the provider are sitting, and with a very open book agenda. You are not going to, it doesn't help to come with a preconceived notion of what you want to do, unless obviously it's a very severe condition that something has to be done. But give them a chance to speak, answer their questions, give them the facts and treatments of what treatments that I just mentioned, and also see how it will work with their lives. For example, some years ago, a parent wanted to do diet, but the parent said that I work evenings and my spouse is just not going to be able to handle dinner with his dietary modifications. So really what happens in people's lives is really important to bring to the clinic and give them a chance and an opportunity to voice and speak, and not being felt as if they're being led into something. And with that, and at that point, we also share with them, somewhere along the discussion happens, is why do I need to do something? Even though you told me, doc, it's a chronic condition, it won't go away easily, but what if I don't do anything? And there you kind of build up on what made them come. Like Sam's son, Cam, had issues with eating and was told his behavioral issues, and she wanted a quality of life back for her child. Or a patient may have repeated food impactions. I had a child last year where a sunflower seed impacted, which is such a small thing, but it got impacted. And you don't want the family to be looking over their shoulder every day the child eats to see are they going to get an impaction. And then over time, if things are not done, I tell that upfront to families, is there could be narrowing and scarring of the food pipe. So with those discussion points and those potential outcomes of what could really happen. Now, you don't want to create a negative, or if you don't do something, it's going to happen like this, but rather if you do something, that this is going to make their life better and easier, builds up a positive platform for the families to start talking about in a positive light. And I would like to hear from Sam on how her journey was, how discussions happened with her, and how did her family feel welcomed.
Okay, so for Cam, once we got his results back from his scopes, they told us that it was EoE, and the doctors laid out all the different options that you discussed earlier. They told us the pros and cons, what they felt given Cam's condition and where he was at, what treatments would be best for him. And then we just had an open discussion for probably about 10-15 minutes in the doctor's office, just trying to figure out what would work best for Cam and his lifestyle and the different medications, the elimination diets, what we felt may be his triggers, even. And we allowed Cam to be very active in that conversation because he was 11. And so we felt like he would know what he could maintain on a daily basis. And so the doctors laid it all out, and we actually did multiple different things. And we saw what worked, and then if we felt like it didn't, we reevaluated and just kept that very open line of communication. And the doctors just continue to help us formulate that treatment plan according to what worked best for Cam and where he was at in his EoE journey.
How did it feel? No, thank you for sharing that. How did it feel to undergo endoscopies? Like, how was it received by you and your family and Cam?
So initially, we were very fearful, honestly. We have never had to put Cam through any kind of procedure like that. And so it was a little intimidating. And I feel like most parents, with they're blindsided by something, may feel similar. And so just having the doctors lay out the benefits of having an accurate diagnosis and finding the right treatment plans for your child at that stage, it was very important. And having them listen to our concerns and explain it to not just myself but to Cam, so he could understand that this is a lifelong journey that you're going to be on. And so we have to take action. What are you comfortable doing? We should probably work on having this PPI because you've got a lot of reflux, but maybe this milk is what your trigger is. So, can we implement both? Are you comfortable going to school and not consuming these types of foods? So, we just had a very open dialogue just to try and figure out what worked best for him and where he was at.
No, thank you for sharing that, Sam. And I think it's really important to have that open dialogue because it's very natural to feel that we are experimenting on the child, that the doctors don't know what they're doing or what they want. And it's really important to know that these are very separate buckets of things, and we don't know which is the best size will fit which person. And it's very important for us to be mindful that the family and the patient don't feel as if we are experimenting and navigating the dark on what to do for them.
And pushing something on families that they're not comfortable with yet. That's another big one. We were able to make that decision alongside a doctor as opposed to being told you have to do this or this is going to happen. Being a part of that conversation was huge.
Absolutely, you're absolutely right. And we'll take the next few minutes to go over some of these therapies. They have been around for many years now. PPIs are very familiar. In EoE, they're used more as an anti-inflammatory agent, blocking STAT6, rather than proton pump inhibitor activity of decreasing acid. And it's important to explain that to the family that I'm not using really for acid blockage, but rather to decrease the inflammation that may happen with EoE. And the dose is usually twice a day to the maximum adult dose, or depending on the child's weight, 1 milligram per kilogram per dose to the maximum adult dose twice a day. And then I would do an endoscopy after 3 months and see if how things look. Earlier on, it was more a treatment. It was kind of a diagnostic criteria, but in 2018, new guidelines came out called AGREE, which made it actually a first-line treatment option. Moving to dietary modifications, we covered most of it. It really it can help you get to the root of the potential offending agent, but also the journey can be a little heavy for the family. That is top heavy for endoscopy in the first year or two till you land on those foods if you do. But there can be elemental diet or empiric diet, and which is on the next slide are the 6 food, 4 food, 2 food, 1 feed. And you'll see that milk is standard all across, and then you go down the list. And if you start with 6 food, you reintroduce them in the opposite order. When you're reintroducing this between wheat and milk, there's something called baked milk before you go to straight milk. Topical corticosteroids, the initial study in, I think, 1998 was on Flovent inhaler or fluticasone inhaler, and then budesonide came out in the early 2000s mixed in Splenda or artificial sweeteners. And now over time, that has pretty much, those are the two options that have stayed around, either the fluticasone inhaler, budesonide mixed in a carrier like applesauce or Splenda or NutraSweet or Neogate, whatever works for the family. I try not mix it in a milk-based product because I'm just putting more milk in the esophagus then. And the main thing with the corticosteroids is the administration. It should be done after they're done eating, so that I tell them it's like coating the esophagus, like you have eczema on the skin and you put cream. That's what you're trying to do, is put the medicine in the esophagus so it can coat it. So do it after breakfast, after supper, nothing to eat or drink for 30 minutes, and then drink some liquid to wash it down, because there can be a risk of candidal overgrowth. Not so much candidal esophagitis, but more candidal overgrowth can happen. There are some case reports of decreased bone density with chronic corticosteroid use and adrenal insufficiency and linear growth. So what I do is I keep track of it. I look at the growth chart each time they come. If they're on chronic steroids, I check their serum cortisol level early morning every so often, not more than once or twice a year once they're on staple dose. And then I may do a DEXA scan every couple, 3 years to make sure the bones are okay. Again, these are uncommon, rare, but things that have been reported. The other treatment option is dupilumab, which is a biologic agent. It's an anti-IL-4, anti-IL-13 blocking agent. And this has been around for a few years now, starting off with atopic dermatitis, then asthma, then rhinosinusitis. And more recently in May 2022 for EoE, ages 12 and older. And a couple of years later in January 2024 in ages 1 to 11 years, more than 15 kilos in weight. So if your age is 12 and older and 40 kilos, you get the adult dose, which is 300 milligrams every week. If you're over 15 kilos, but under the age of 11, then there are different doses depending on your weight. And it's also used for some other entities. For EoE, it has been, in my experience, at least a game changer. Over the years preceding to 2022, we were in the spin cycle of steroids, PPI, diet, and the other way around and in between. This has really made things different for us. This is one of the studies that came out on the EoE Kids study, which was the ages 1 to 11 in New England Journal a couple of years ago. And drug, which is in darker purple, and the medium purple worked better than placebo, which is in the light purple, both by histological criteria and endoscopic criteria, and improve the growth of patients also. When to use dupilumab, it can be used first line. Normally, often it is used as stepped up therapy, but for first line use, if you have someone on multiple corticosteroids, like something for their sinus and something for the eczema and something for the asthma, the last thing I want to do is put another budesonide formulation for the EoE, and that may be a consideration to use dupilumab because it will hit all of those things. Or if the family really doesn't want to do, like I had a child, like Dr. Didel was saying, going to college earlier, is a child going to college in many miles away from here, and the young adult is in band and has to be out of the dorm at 5 in the morning and not get till 9 p.m. And the patient is like, I really can't take any medicine or do diet. Can we do something less frequent? And it dupilumab work for their quality of life, and that's what we did. And then you have reasons as a step-up therapy if you have difficult to treat or symptoms that don't come under control, or your current diets are not working, or you have a narrow caliber esophagus. The child with the sunflower seed, he had narrow caliber, and I put them on dupilumab. I'm like, I'm not going to wait and experiment here, quote unquote. I'm just going to go top of the line here. So these are some of the real life situations we run into. And finally, we'll have Sam talk a little bit about what she and her family did and continue to do to improve adherence, because these can be heavy. It's not a one-time treatment. She has been through all of them, the medications, the dupilumab. I'm not sure whether you went through diet or not, and I know you're at least an hour or two from the medical center where you get care. So there is a logistics issue, school issue. So you may want to give us some of your perspectives on how you have navigated this.
Yes, so we have done a little bit of everything, I feel like. We've done the PPIs, the biologic, the elimination diets. The dupilumab is what we are currently on and have seen a significant improvement in his quality of life. He plays a lot of sports, and we feel like it has just helped him get back to where he was prior to his initial diagnosis. Now he still implements the elimination diet. He, there are certain things he knows trigger his EoE, and so he steers away from those things. But it kind of like you referenced a moment ago, he's a child and he knows what works for his lifestyle. And so taking a slurry at multiple points in his day wasn't optimal for his lifestyle. And so dupilumab has really changed that for him. And honestly, it's given him the best quality of life since going through the whole EoE journey.
Thank you so much for sharing that, Sam. I will now turn over to Dr. Lydale for the third and final segment of our presentation today.
Thanks so much. Such an interesting discussion. So I'm going to be interested in Sam's perspective on this too, but I love the way, Sandeep, you keep saying this is not a one and done. This is a chronic condition, and we do need to sustain long-term follow-up and monitoring. And a lot of that is around preventing complications in pediatric EoE. We don't have specific guidelines yet on how to do follow-up, but there are many experts out there, including Dr. Gupta himself, who've been a part of putting together algorithms with structured follow-up recommendations. Much of it involves consideration of repeat endoscopy after 2 to 3 months whenever you change something. So that might be that you actually need to dilate a stricture, but it also can be in trying to figure out which is the right treatment. And it can take, 1, 2, 3 endoscopies before you say comfortable that they really are on the right treatment. And then we want people to continue to come back. So at least once a year, sometimes, again, to the college kids, it can be into the 18 months to 2 years that you're coming in and you're talking through what's going on. And that's where I will start asking a little bit more subtle questions about what are meal times like, because sometimes people don't realize they're having symptoms, which I'll talk about in a second. But that follow-up is really critical because there is this disconnect between symptoms and histologic activity. And we know that the inflammation alone doesn't explain the spectrum of symptoms. So some people really don't have much inflammation, but they have a lot of symptoms. But the other thing we know is that patients can have narrowings or fibrosis, and we don't really appreciate that until we have managed to get all the eosinophils gone and we still realize there's a narrowing. That can be when you realize there's fibrostenosis. So again, not waiting for food to get stuck is what it's all about. I am curious, Sam, you said that your son is an athlete. I find a lot of my patients have flares in the fall and the spring when there's pollen out. That's when the symptoms are really bad. And of course, also when you're eating hot dogs out at the grill. And so, this issue of recognizing it's a chronic relapsing condition, there could be other comorbidities like seasonal allergies, food allergies, or asthma that could be making the symptoms worse. And of course, kids are kids. So either they are in denial. I also have a son, he's a little older now, but they're not the best at saying, yeah, actually, maybe I should say I'm noticing something. And little kids, of course, can't tell us what they're communicating. So sort of curious, have you found this, that he's able to pick up on his symptoms now, or are you feeling like, tell us a little bit more about your experience there?
Yeah, so we're 2 years plus into this, so he knows when his body is about to experience a flare. He has certain symptoms that his body constantly exhibits. And what we found is sometimes it is triggered from dairy, but that is his trigger. And he ate it in something maybe he wasn't aware it was there. There are things that he doesn't consume and he still has a flare. And so we have actually realized it's those environmental allergies, and he can be doing everything right. And particularly when he is outside playing baseball and things, he's got those flares. They're like clockwork. Twice a year, I can tell you exactly when he's going to have them, no matter what he consumes. And so he knows what to be aware of. and he knows when his body just needs a break and what that looks like when that flare is coming on, and maybe different ways he can work with his body to help minimize those symptoms a little more. And just I think recognizing them it's a big step, and I understand a lot of kids can't do it when they're younger. They don't really know what to look for. But once you have the same symptoms repeatedly, it makes it easier to know kind of how to manage that going forward.
Oh, that's fantastic. And obviously, again, I think building that therapeutic relationship with a patient like your son is so important, so we can help it sort of demystify what's going on. It's not in his imagination that when baseball season's happening, it's getting worse. So, biologics are certainly a very specific type of therapy, and we want all patients with EoE to be monitored, especially after changes in therapy. But with biologics in particular, I think we want to know that they're doing the trick. And so you can see improvement in symptoms as soon as 4 weeks after starting therapy with dupilumab, the biologic that's currently FDA approved. But to really measure and make sure that it's truly made those eosinophils go away, it's recommended to do an endoscopy about 5 to 6 months after starting dupilumab. So for Sandeep's college student, that's probably going to be in the Christmas break or something like that. You could sort of repeat and make sure you're in the right place if you started it before they go off to college. But of course, where we are now is to what you're describing, Sam. If somebody feels like something's happening, it may be appropriate to do an endoscopy. So that can really be at the physician's discretion to say, all right, let's see what's going on. Let's see if I can understand it. And the other thing these days is sometimes we also want to be reassuring. Hey, we looked, actually, it looks okay, because people have spent often, it sounds like 11 years of Cam's life was, with these symptoms before we were able to understand what's going on. So that can take a while to not have that worry that you're starting to have a flare. So sometimes you may do an endoscopy to answer the question is actually you're okay, which can be helpful too. So those endoscopies, as Sandeep said, are really the only way to really understand what's going on, but they are certainly appropriate depending on the circumstances. In terms of reducing loss to follow-up, I think this is something we all worry about. Sometimes people feel so good that they just disappear. And we do want to make sure that patients are engaged in understanding what they're thinking about, or starting to have a more nuanced thought about what could be their triggers, like you're describing. We also, if people really don't like the endoscopies, we want to make sure they're aware of the latest and greatest. And I think all of us want something better than endoscopy for monitoring. And right now, sort of a hot topic is transnasal endoscopy, which is a way of looking without needing sedation. We actually use VR goggles and sort of watch a movie while we do the procedure. Again, an older kid who understands what is going to happen is easier, but that's even been done in very little kids, 3 years old, 4 years old. So transnasal endoscopy is a way of making it not as dramatic a procedure, but it's I think we're going to get even more options as time goes on. So keeping up relationship with your doctor to hear about what's happening and ways to monitor the disease is going to be important. We do want to monitor closely, though, for those flare-ups like you're describing. We want to make sure if other people need to be involved, like dietitians or allergists, that we have them involved. And of course, we want to make sure the kids are growing and that they themselves understand what they have to do when they do finally really become teenagers and go off to college, which will happen. They will need to be able to do the medicines for themselves, and so really making sure the families understand the importance of adherence, but also the child themselves is starting to own it, and their different apps and things like that, educational support can all be helpful. I'm sort of curious, Sam, what you're doing to get Cam himself in charge of his own medications. Are you guys starting to have that discussion, or?
We are actually. So he is now a teenager. And so we are kind of nearing that stage where we understand that he has to take charge of his own health and have that mindset that, he really needs to be a part of the decision making. And we encourage him to listen to his body, and only he can tell us when something doesn't feel quite right. he's got to learn to advocate for himself and be mindful that this is a lifelong disease that he's going to fight. And we want you to be comfortable with the treatment that you're on. So that way, when you do go to college, you don't veer away from it and you don't cause, permanent damage or have all of these complications because you didn't feel like you had to stay in it at this stage. And so that's a big conversation that we have in our home for him is just, this is his body and he has a say in things. And now we obviously bounce all of those decisions off of our healthcare team. But he is very actively involved in that. And it's specifically because of his age. And we want to make sure that his lifelong quality of life is there and just that he's able to uh, monitor that and know what his signs and symptoms are and help him understand what is right and wrong for his body and where he's at in his journey because we've been told it will change as he grows and evolves, so we just want to make sure he understands that.
Yeah, children definitely change, but I mean, again, you're in that what we call transition process, and anybody in pediatrics knows transition is not flipping a light switch. It's not, a quick thing. It's really a process that is over many, many years. But certainly, believe it or not, you're working your way towards adulthood already. So, I don't know, Sandeep, if you have any favorite ways you get your patients engaged in this, or apps or things that you'd use to try to.
No, that's you're absolutely right. You don't want to lose them because if they feel good, they may not show up, and they may not show up if they don't feel engaged. So it's really important on our part to make sure they're engaged. But the other thing I tell families, especially the patient, is once the disease is under control, I ask them, okay, how do you feel now? Just like Dr. Lytle, you said, you ask about meal times and other things. I said, no, remember how you feel now, and remember how you felt 3 or 4 months ago. Because you had felt like that for 3-4 years, you didn't know what normal was. Now you know what normal is. And as Sam said, her son is attuned to his body now that he can feel something is happening, but important for them to be in charge. And I highlight for them, remember how you feel now. This is how I want you to feel. If you don't, let us know.
All right. So I'm going to bring us to some summary and concluding thoughts. And we hope that these 4 points have been made throughout the presentation. First, it really is all about early recognition. It really does matter. It's about everyone out there in medicine hearing symptoms and thinking about a child as possibly having eosinophilic esophagitis. Unfortunately, pediatric EoE often has delayed diagnosis, probably because people haven't heard of the condition. That's why we're grateful for a chance to provide education here. And then once you're thinking about EoE, really putting right away on the table that you're thinking about it, but you have to send the patient to the gastroenterologist because it's going to be evaluation with endoscopy and biopsy. That's going to help you get to the diagnosis. Once we have a diagnosis, it's all about timely treatment. That's how we avoid complications. And there, I think early intervention is really how we can reduce risk of strictures. So you're not getting that damage to the esophagus. You can reduce the impact it has on feeding, and you're seeing less feeding dysfunction and a child thriving and in general having better quality of life over their long term. And there, I think we really hopefully illustrated for you the importance of shared decision making. I really did enjoy that this was a conversation we had today with Mom, with Samantha, who was so gracious about joining us. But what you heard throughout is her real intentionality in bringing her son into the discussions. And it's really that partnering with families that's going to ensure understanding, engagement, and adherence to treatment, not just from parents, but from the child themselves, especially as they're going to be growing older with this condition. And also that they're going to remain connected to their care team because it's all about ongoing monitoring. We do want regular follow-up. We do want multidisciplinary care. That's all critical for sustained disease control and making sure we've supported a patient as they're growing. So with that, I really want to thank you all for joining us today and listening to this presentation. I particularly want to thank Dr. Gupta and Sam for providing insights to this discussion. And we're really hoping you found this activity to be useful to your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the American Partnership for Eosinophilic Disorders. This program is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/BHC860.